Please welcome to the stage Dean Anason, Dr. Nkem Chukwumerije, Kathryn Lawler, and Shannon Sale.
All right. Let's get started. Good morning, everyone. How's everybody doing? Are your brains full yet? Leave a couple of gigs for these folks because it's a good panel. All right, so this is the increasing access and improving outcomes across the Southeast. There's at least two very important words in that title, and we'll discuss them. I want to get right into it. We have 40 minutes. Let me start. I just wanted to start by asking, what does the term access mean, and how has your understanding of that ability evolved or changed? Kathryn, you want to start? Let me start with you.
Sure. Yeah. So it's great to be with you all, Kathryn Lawler at Mercy Care. And so just to get the conversation started, obviously most of us, when we think about access, we do think about insurance and whether individuals are insured. But we know, and our three organizations work very closely together, that is a piece of it, but also individuals' ability to get into services, ease of service, convenience, navigating services, the ability to feel welcome in those services are all a really important part of the access equation.
Nkem?
Yeah, no, thank you very much. So when I think about access to total health, which is access to insurance, of course, to get medical care. But do our people have access to mental health care and the access to the social services that they need so that they don't even get sick? So it's really looking at it from those aspects and also considering geographic access too, right? So you may have access to care, but can you really access the care itself?
Great. Good morning, everyone. I'm Shannon Sale with Grady Health System. I certainly echo everything that's been said. Also think about access when we think about how do we get to people, meeting them where they are. That could be, certainly within our four walls, but how do we get out into the community and improve that access, that engagement in care? Could it be mobile care? How do we use technology to really connect with folks and again engage in their care plans, engage in healthy care and healthy lifestyles overall.
Great. You all have touched on it, and I want to delve into a little more. What are the contributors to health besides what at least a lot of lay people would normally think of, like clinical care and medicine, prescriptions? Outside of those things, I think you all have hinted at already. What are some of these other contributors? Nkem, would you like to start?
Yes. No, thank you very much. I think I kind of said it before. I mean, the World Health Organization defines healthcare as being a state of well-being that is physical, mental, and social. And there's a reason for that. So when you talk about, healthcare, it's really about making sure that people have the physical well-being is what we focus on, but the social determinants of health are really, really very important in the communities where members and our patients come from. So that's kind of how I look at it.
Yeah, if we had a slideshow up, we'd probably have a picture
That's
of
not allowed.
It was not allowed, but we'd have a picture of a body, and about 20% of that body of the health of that body would be related to what happens within a doctor's visit or a hospital stay, and the rest of it is the social determinants of health, as was discussed. So, really looking at food access, transportation, housing, workforce development, being able to tie all of those components into health and have a healthy society based on that is really all about our access and living a healthy life.
Kathryn.
And I think what I can add is just as those of us who are focused on these issues and you in the room, I think it's always helpful to remember that 100 years ago, we wouldn't be having this conversation, right? Because we also didn't live very long. So life expectancy was only about 40 100 years ago. And all of the advances over the last 100 years means we now get to have this conversation about health, not just helping you not die at a young age, which was a big part of it, but now we get to talk about a fullness of life, well-being, but that means that we have to broadly expand what the work and our frameworks for helping people get healthy and stay healthy. And that's just what they've emphasized.
So we've kind of defined our term there. What's the state of access now? How good or bad is it right now?
So we could have more.
Yeah.
I think that it is challenging. I think on any given day, we are talking about how do we get folks, again, into health? How do we keep them into health? What are those barriers to health? One of them is, of course, insurance coverage and making sure that folks have coverage, have a card or something that helps them to feel that they have that access to the right care. We can talk about anyone can go to the emergency department. That's not the right place to access care. Emergency departments are full. They're for emergencies. And so being able to provide our communities with that knowledge of how to use the healthcare system, that ability to do that through some type of coverage, and then being able to have enough physicians, enough clinical staff to care for them. Those are all components of that access that are all, quite frankly, not meeting the demand that we have.
Yeah, so the components of access for us is, if you think about it, you talked about insurance, right? In our country, you have to be employed, or you have to be very poor, or you have to be older to get insurance. So there's a huge segment of the population that is uninsured. And the challenges in healthcare, for example, is, the individual marketplace is a place where this segment is getting insurance, and there might be challenges, in the coming months in making sure that people can actually get in to be seen. And then when they have the insurance, we also have challenges of healthcare workers, for example,
right.
Mental health, right? One out of 7 Americans have mental health challenges, and yet the mental health providers is 1 in 350. So how do you ensure that we have the workforce to take care of people? So that also affects access. So when you think about access, you think about it, like I said, from physical, mental, as well as social well-being. And the social gaps and challenges in the communities of connecting people back to social services is also an opportunity for us.
Well, you bring up a good point that I hadn't thought about, is there are a lot of patients out there, people out there, but their situation is different, their demographics are different. Are you trying to, Kathryn, focus on the group that's, are you trying to take care of everybody in your organization? Or are you trying to focus on that gap group that doesn't fit in any of those categories? Or is it really a focus on everybody?
Great. Yeah, that'll be a great question for these two as well. But at Mercy Care, we're a federally qualified health center, and we specialize in serving individuals who are experiencing homelessness. So the vast majority of our patients are uninsured, but that's why we exist. So we do focus on those who don't have access to care and any other opportunity, though all are welcome at Mercy Care. And the changes we're seeing around access are just the huge rates of housing instability for our patients and how that's affecting their ability to prioritize health and get to care. And then to add, I think, to what you said, the complexity of their mental health challenges. So definitely strong prevalence of mental health concerns, but the complexity of those has changed notably. And so I think, yes, we are open to all, as I think are all of these organizations, but our focus is specifically on those who are uninsured.
And Shannon, at Grady, how would you guys answer that?
So our mission is pretty broad. We have our focus on expertise in trauma and high acuity, trauma, stroke, burn. Everyone knows that. That is or many of y'all in the community would know that. But we also serve, have 600,000 visits a year for folks managing their primary care, their chronic conditions, and so and certainly behavioral health. And so we do have access for all. We focus on all, and then we try to target our services for those who need that support to those who need it the most. And those would be folks who are likely uninsured or underinsured and have social challenges around housing, food, workforce.
And we'll get more into some of those programs in a minute.
Yeah, I just wanted to add, this is just a moment to recognize our partnerships too, right? So we in Kaiser Permanente, our mission is to provide high-quality, affordable care to our members, but also to improve the communities where our members live. So we try to partner with organizations like Mercy Care and Grady, in our community benefits, right? We give, like for example, last year we get about $63 million in Georgia here to our community partners. And and also some services we provide to those who don't have resources within our own system. So we partner with Mercy Care. In fact, I was at the Gateway Center last week. I was just sharing that with Kathryn. And I saw Mercy Care embedded in those services, helping homeless folks with recuperative care. So that is really, really very important. And I think Kaiser helped contribute to that. We also partner with Grady. So this partnership and collaboration is very important, for us to, continue to do the work, because community health requires everybody.
Yes, we are very grateful for that service, as that's where many of our patients go into recuperative care. So you can see kind of that collaboration across our organizations between how it's funded, how it's operated, and then who it serves. And those would be many Grady patients are part of that program.
Great. Well, we don't need to tell this group that there have been a lot of budgetary and policy changes in 2025 when it comes to health care. And we're not necessarily here to list or evaluate all of those today. But in terms of what you do, in terms of the impact on access, could you talk about that a little bit? Kathryn, maybe start.
I think the most immediate thing that we have seen is because of the high volume of changes and how regular citizens are aware of the significant change, that has created some confusion among our patients, and they are not accessing care at the same rate. So when they don't understand if those changes do or do not impact them, there is a hesitancy, and we're seeing, not able to get people in as quickly, delays in getting their care. So I think that's where we are right now in this moment of change, is that the confusion does change people's behavior, and that shows up pretty quickly for us.
And how have you tried to address that? Or are you still trying to figure that out?
Sure. No, absolutely. So we're not near as large as these organizations. So we serve 19,000 individual patients through 85,000 visits. So we are able to do a lot of individual outreach and preemptive and recognizing patterns pretty quickly. And so letting people know, getting in touch with them. I mean, anyone who's gone to the doctor or the dentist here, the 9 texts you got to confirm your appointment, we do that same thing to our patients. So helping them remember that they're here and that care is available as much as possible. So, but these are by definition people with very complicated lives, and when they sense another complexity, it's not necessarily the top priority.
Adds to the stress.
Yeah.
Nkem, what do you think the impact of all this change will be on access?
Yeah, it's going to be challenging for our citizens that lose insurance, right? So, like I said, the individual market, there might be people who lose insurance. And for us in Kaiser Permanente, we try to help them transition their care. So we have a medical financial assistance program that helps these individuals as they transition to find other services, right? And we do also have, some complementary insurance programs for those who don't have access to care. So we try to do that.
So when you say transition, you're trying to transition them from your plan to another plan or another form of coverage, or?
Right. So we do provide full care to our members.
Right.
However, like I said, we have a lot of community connections.
Right.
So that when we cannot, we provide those transition care to other services like the federally qualified health centers and other services that can continue to provide that care. So we commit at least 3% of our revenue every year to community services to make sure that we're those that we can take care of internally, that we're actually helping them, get services externally.
Right. And do you think that percentage will change or grow, or you'll be able to maintain it?
But let me start by saying we don't want to lose these members.
Right.
We wish that every American had access to health care. That's really the idea here, and that we're able to keep them. So we do everything we can to do that. Yeah, we it's just the challenges of American healthcare system. How do you take care of people who are uninsured? How do you manage that? Which is exactly why we have these partnerships to do that.
Shannon.
And I'll just add, similar to both, as we go out into the community, we're adding financial counselors or financial assistance teams to help folks understand what their access, what their eligibility might be, and what programs that they can get into. We kind of do that at all stops along the health system, whether it's someone comes in for emergency care or inpatient. Certainly, where we want to be doing it most is on the outpatient setting, or even in community events where we may be doing screenings, and we offer that service with folks too, just to try to get that support to people along the way. As Kathryn said, there's a lot of complications just in anybody's life, but in someone who might not know where that access is or might be facing other big decisions on a daily basis, to be able to help to alleviate that for folks is what we try to work to do.
Not to put you on the spot too much, but just to kind of make it as real as possible, could you give an example of the kind of things somebody might be transitioned to? I mean, they might be losing in one area. I mean, could you just give like a generic example?
So in terms of a decision that folks might have to make, do they pay for their prescriptions, or do they pay for food, or do they pay for their rent, or do they pay for their prescriptions? What assistance might they get for healthcare to be able to say, I can go to the doctor today or not? Can I pay for that ride to the physician's office or not? Do I have somebody to go with me if I need my colonoscopy because I can't drive myself home and they won't let me go? So I'll come in, I might have done all my prep, but I can't get home. And because nobody's there, they won't let me do the prep. So there are all the things that go into how we manage our own lives. If you don't have that support structure, or you're having to face those questions on a daily basis, that is going to be a challenge. And then you might just say, I got to do something else today. I can't do that. And so being able to help to support folks, I think, through any type of whether it's a social worker, community health worker, which I know we'll talk about in a bit, or financial assistance counselor, or just kind of creating a network for folks to be able to bounce those questions off of, which again is how we try to work together. And
the point is, if these practical challenges aren't solved, then the care doesn't happen, right? Yeah. I wanted. Did you want to add something?
No, I was just trying. Similar thing. We have a community support hub. And the community support hub, they screen our members for nutrition. Exercise socialization is very important for the elderly. Caregiver support, compliance with medication, and any additional resources. And we try to work with the community partners to make sure. You were asking me what we do to help these folks. So it's really, those are the things we screen for.
And could you give an example of the kind of community partners you work with?
We work like Mercy. Grady.
But of course,
we also work with Food for Medicine. We donate with Atlanta, food services and all that. We work. We do really work with a lot of community networks, right? And this is food is medicine is a big thing. I think we donated about $300,000 this year to. This medicine program.
I'd like to explore that a minute. I want to talk more about partnerships, but I've gotten to meet you all, and we've talked a few times, and food was something, especially as I look back at my notes, came up again and again. That's very important to your programs, right? Could you talk about that and the idea of a well-fed family is kind of a central goal here, and a healthy diet,
So I'll take that first. We all kind of address it, and we all address it. We have different approaches. On the Grady campus, for a long time, we had a fast food restaurant kind of at the corner there at Jesse Hill and Gilmer. And we were able to convert that to what we call our Jesse Hill Market. We partnered with the Atlanta Community Food Bank. If y'all are here, thank you. We also partnered with Open Hand folks to get that started. We built into our electronic medical record a referral so that as we screen our patients and understand that they are food insecure and have a condition that is food dependent, they get a food prescription to go to that pharmacy. And they get food. They're given a box of food, I think every other week. They have nutrition classes, and they have individual nutrition visits. And the fidelity of the model is about 6 months long. We have graduations when they work through when they get through the program, and happen to have stumbled upon a couple of those as folks are finishing up the program, and it is touching. It is very emotional for folks. Almost everyone who speaks of the impact of the program is in tears. They talk about how not only they got healthy, but their family got healthy. So being able to have this program is addressing the adult, mostly. We provide mostly adult, but it's also the children in the home and other loved ones. And we've actually also shown statistical significance on reduction of A1C and reducing and managing
from the
A1C.
change in diet,
From
the improvement in diet. And in the case of Grady, could you talk about who some of your partners are that actually provide the food?
So Atlanta Community Food Bank is a
Right.
strong partner there, and we work together with them. Open Hand, Good Measure Meals was a good partner for us as we went into that. We've certainly received a lot of funding from folks, maybe some of y'all in the room, and we are very grateful for that. That's how that program goes. When folks are with us, we also screen them for eligibility and their opportunities to connect to other supportive programs that they may need.
Kathryn, you want to discuss the...
I'll add, their work has actually been a major leader in our community, and I think very inspiring. Maybe to add to that, so from our patient perspective, and similar to what Grady and Kaiser do, we screen folks for their unmet social needs. And so initially that's often, I'm not going to be able to buy groceries this month. So we're not going to make it. We know we don't have enough. So talking about just stabilizing. And then because we integrate our primary care and behavioral health care, what we find is that once we can get any of the stress, anxiety, and depression under control, it really is that opportunity to engage. So we have cooking classes, we have group classes, all about those lifestyle changes and prioritizing health and how important that is, and very similar big changes that people can make. But the first part of stability and being able to get through the month is very important, kind of like the fertile ground for where all of those other changes have to take place. So by integrating behavioral health and primary care, we are working to be able to address those underlying stressors more quickly as well.
Nkem, is there anything else you'd like to add on that topic?
Not additionally, we have similar programs. We do have in some of the KP facilities, farmers markets, and also we have a Center for Healthy Living that also emphasizes the essence of nutrition. Like most of you know, if you change your nutrition, it can affect your blood pressure, diabetes, a lot of stuff. So it's an integral part of the care we provide to our members and the communities.
Let me stick with you and ask you this next question. Technology is an influence on all our lives, and I think telehealth was one of those kinds of services that really grew. I think pushed in part by the pandemic, and I think it's become much more widely used in recent years. Has that helped access a lot, or is it more complicated than that? Could you talk about that a little bit?
Yeah, no, thank you very much. Telehealth, when I think about Georgia specifically, we now have challenges in the rural communities for access to specialty care. So each time I think about it, I wonder how we can use telehealth to improve access to specialty care in the rural areas. For example, and that's what we learned from Kaiser Permanente, because let's say teledermatology, we're able to actually have our primary care physicians take pictures and send it to the dermatologist, who reads about 50 of them in 4 hours. What if we were to do that and extend dermatology care to rural aspects of Georgia? So it's an opportunity for some of us who are thinking about how to partner. We have a lot of specialties in these urban markets, but how can we extend using telehealth these services to rural areas to improve access and outcomes?
I can say personally, my mom's 96, and I help her with her appointments, and the telehealth on the dermatology is a fantastic thing because, we tried it, and I realized, once she had gotten to a certain point in her recovery from her problem, I'm like, we don't need to go there. And when you're 96, anywhere you don't have to travel is a great thing. But the pictures, they do a lot with the pictures, that we send, thanks to our phones and our iPads and whatever, those of us who have them. So Would you like to talk about telehealth?
Yeah. So, I mean, as you mentioned, the pandemic kind of put the accelerator on that. We had it was a part of our 2020 strategic plan that we thought might happen over the next 5 years, and it happened in 6 months, and kind of went up, and then has definitely settled back down in terms of for visits. But what we're using it for specifically would be if somebody doesn't show up to an appointment, maybe transportation was a barrier, we can flip that to a telemedicine visit very easily. So helping to try to bridge those gaps in care that might happen.
Could you even have done that in 2019?
No, not at all.
Yeah.
We did not have any of that technology. We have built a telestroke network as well, so that we can reach out to folks in rural and smaller communities that might not be able to that don't have stroke care 24/7. So being able to bridge some of those gaps, both locally and with our patients in the market, as well as extending expertise across the state.
Have y'all's clients adapted well to that? Or?
Yeah, in our own way, the same exact story. It really just took off during the pandemic, and just I think the promise of telehealth. Ours is a great example in that we serve the vast majority of our patients are at 200% of federal poverty or below, and yet it has been incredibly productive to use telehealth, particularly around behavioral health therapy. So it has been a game changer in terms of people's access, the ability to, not the first visit, obviously, but once they're in care, like you described with your mother, once you're in care. And so if we can do it with our patient population, many of whom are homeless living on the street, I think the promise of that technology is tremendous.
That's great. That's great. Could you all talk a little, we've referred to partnerships a lot. We've already talked about how some of y'all work together, but could you talk more about what new partnerships you're trying? I know our audience is interested in that, and what new business models you're trying. Whoever wants to start first.
Okay, at this end, I will. So I think this could be a fun topic for the entire day. So hopefully every panel will talk about partnership because it is a key to so many things that people do. I think I would just like to highlight that our major campus is just very close to here. And we were able to not only expand our campus recently and increase our services, but we have built 170 units of affordable housing in partnership with a housing developer. And we'll break ground in a couple of weeks on our next 98 units. And that's, I think, the kind of more innovative thinking that people can bring to solving the ecosystem that not only we're operating in, but our patients live in.
And I'll add, so we are all a part of, and some of you in the room are, of the Atlanta Regional Collaborative for Health Improvement, which is all about partnership. It's about convening folks with a direction, to tackle the right direction of advancing healthcare and making healthier communities in Atlanta and the region. And so we work together on a number of initiatives. One would be community resource hubs, where we are using a technology and taking an approach that you don't have to replicate or repeat and resolve from the ground up every time you start it, that we have partnerships with the folks that I've already kind of mentioned, whether it's the food bank or workforce development or other transportation, utilities, the services that people need, but being able to optimize that through a technology platform that helps you to make a referral, close loop that referral. We're kind of taking that model and spreading it across each of our areas with other partners within the community. Other health systems are also using that. And so being able to we're not going to all kind of report up to one entity. We want to take kind of the right models and replicate them and create that scale to be able to make a change overall. And that's the whole intent of the Archie model, is that we bend those curves around extending life expectancy, going up, reducing chronic conditions, and improving health overall.
Go ahead.
Yeah, so for us, we have various partnerships where the TSPMG Cares is a partnership of our physicians partnering with federally qualified health centers, Bethesda Clinic, for example, and some mobile clinics to provide care to the community. So, so these are physicians who want to provide care, and we give them the time to actually get it done. So we do that. And also we use community health needs assessments to find out geographic areas where there is need, and we have a mobile van clinic that we actually take to those areas. In fact, last year we did about 106 events and touched so many lives. So there's a lot of connections we have in those partnerships.
And I want to come back to part of that in a second. Shannon, I want to ask you too, your board, if I could say, seems like quite a lineup of really all-star business people. That's got to help in terms of developing partnerships, right?
It does. It helps with looking at things differently, like as Kathryn was saying, looking at new and different models, as well as really pushing us to be efficient and thoughtful in how we operate our health system, as well as connect with folks outside of the health system to make that happen. So we do have a very strong and engaged board that really is helping to drive the overall health of the community.
Yeah, that's got to be exciting. All right, so many questions I want to ask here, but I'm going to be good. Could we talk a little bit about someone who's important in my life put this question in my ear? How are you all using community health workers, and how do you find them? Who are they? Great. Kathryn, I see you nodding. You want to start?
Yep. Yeah, well, very specifically, Shannon mentioned that we are both sites for Archie's community resource hubs. And so what literally happens is when we have a patient in care whose chronic condition is not, we're not moving the needle on their chronic condition, primarily hypertension and diabetes, through our own care, they are then flagged to meet and partner with a community health worker. And that can be over a period of time, who not only works with them on their medical condition, but also really to understand what's going on, what's important to them as an individual, what maybe is their larger family context, and then, as Shannon said, to help directly connect them to the services they need. Almost always, our patients have a housing concern, whether it's paying their rent or utilities, or literally they don't have housing, and then from there, economically stabilizing. So community health workers are amazing in the way that they can obviously integrate great medical care, but really get to know a person, understand their values and decisions, and help align that great medical education we've been giving them with their reality and help prioritize so that it can be actualized. So that's been a great, powerful example for us.
If I could add about community health workers, we've been working for quite a while, I'd say about 10 years, on kind of the definition across all of our three organizations and others within the community and the state, public health, on the definition of a community health worker and a certification pathway for them. It is a position that is not funded by a direct payment, and so we're working on being able to move that to a position that you would be able to bill for, to help to create that sustainability. It's a critical part of the healthcare ecosystem. We think these folks, they're in the communities, they know how to navigate the communities, they know how to connect with people. So we know that it is a critical part of folks staying in care, staying in that care plan, actually helping them to get healthier. And so working to kind of solidify that role, kind of give it a certification and draw some of the funding that would help to support the sustainability of that model is something we got this close last year. I think there's lots of support for it. I think just ran out of time in terms of the legislation, and we're looking forward to hopefully being able to see that cross the line this year.
And that was legislation at which level?
At the state level.
State, okay. Nkem, does Kaiser Permanente use...
We typically connect our members that need services to our partners who use community health workers. However, we do have our most vulnerable patients that are very, within our system, where we have limited number of social workers and case managers that actually go into the community to meet those patients where they are. So those be our transitional care programs. So patients who are transitioning, from an acute illness, and then we actually go to see them there. We also have, but not necessarily community workers the way they are used in these areas, right?
And how do you, the funding issue is very interesting. How do you recruit the people? How do you find the people? How are they identified?
Community health workers are most often individuals who have lived experience. So individuals who themselves have had difficulty navigating the healthcare system, or who have struggled with anxiety or depression, or have known what it is like to face economic instability and overcome those. And so that life experience is incredibly important to their ability to connect and help change the lives of our patients as well. There's training and support that goes along with it, but it really is a heart job where people get the opportunity, and we're so grateful that they take it to transfer their own experience into helping others through something similar.
It's also a great career ladder. So it's a great way for somebody who has had lived experience, who might not have had a traditional education path, to get into a position like this, learn, be able to kind of take on additional education.
So they could get some formal training in this?
Get formal training, and then maybe become a nurse or a paramedic or a social worker, and move on. And so it's a great way to enter the healthcare system and be able to determine where you want to go from there.
No, that's fascinating. And am I hearing you right? Are some of these your former clients?
Yeah.
Oh, yes.
Definitely, yes.
I mean, that's how you know some of them, right? I mean, it makes total sense. Yeah. Okay. All right. We have about 6 minutes to go. So I think one of the most important questions, I think, of the whole conference, I want us to spend most of our final moments on. Talk to us about, and let's go in any order that you want, what are the big remaining challenges in access and improving outcomes? And how can anybody in the audience help or contribute or participate in solutions?
I think we've talked about all different parts of access, right? So I think there is, the way I look at it, people in the audience, this is about public health. And public health requires public will for us to do it. So we need to do it together. So be it from the point of view of advocacy and policy, you can help, right? And you can help in either area, either about insurance or giving access to care. We talked a little bit about geographic access. If you think about it, there are no barriers now. There is telehealth, right? We in Kaiser Permanente talk about home first. So we're beginning to think about if there is any need for care, can we do it while the patient is at home? Do they need to come to us? So let's begin to think about things differently, right? How do we improve rural access to care? Through telehealth, like we talked about. So I think it's really extending and people thinking through it. How do you extend either your time, your talents, or your treasures? There's funding. Funding is a challenge now in the health industry. How do we make sure that we are helping with funding? So there's so many ways you can participate, so, right? So if you don't have the time, you may have the talent and you may have the funds, right? So continue to think in those areas.
I guess I would add a little bit about how we can collectively and then individually get our arms around some of the change that is underway. What of that change is knowable and predictable, and how we can collectively, but I think of ourselves as an organization, be more proactive than reactive. In a time of tremendous change, it is challenging. It is often easier, or it is a default to be very reactive. And for our organization, right, so I mentioned we serve majority uninsured, and so a whole series of things will happen across our community, which will then create an increase in our patients, right? And some of it is very knowable and predictable, and so how we can be prepared and get ready to see that change in who needs us and how we show up for them, I think is sort of the moment that we're in. It's very, I feel like we've been an illustration today that all of this goes on in an ecosystem. Our jobs are at specific desks, at specific addresses for specific organizations, and it's really easy to sort of take those walls and think about all the change inside. And that's super important, and we would get fired if we didn't. But we also, this partnership ecosystem, what's happening to people's lives, that's all happening in our community. And that's both our challenge and probably where the solutions are going to lie. But we're going to have to figure out how we can collectively kind of lean into figuring that out and doing something about it together.
I appreciate where you started. There's kind of that will of our understanding. You can look at, as Kathryn said, kind of the individual organizations and say, well, that's, I want to support them, or I'm going to support over here, but really looking at it as a whole. I think, as Kathryn said, not to repeat, but underscoring what you've heard hopefully from us today, that it's about health, but it's about all of the aspects that go into health, all of those social determinants. So lean into any one of those areas that catches you, that is attractive to you, or that you feel you have a passion behind, whether it's housing or food or health. All the ways in which we are coordinating care, we mentioned community health workers, those are not funded positions right now. How do we help to either get those to funding or help to support those key connections throughout? Community health workers, navigators, any type of connecting service that helps to drive the overall outcome of a patient and truly the health of our community. We want to be the healthiest community that we can be overall, right? That drives everything. It drives our workforce. It drives our productivity. It drives the experience when people come to town. We want people to see a healthy Atlanta. And so find any of these areas that we've talked about that connects and just lean into it and help us to make a change.
And can people here, if they have any questions, can they reach out to you guys or have ideas?
Absolutely.
You're taking calls?
Yes,
right?
we always take calls.
Okay. All right. I wanted to close, and Kathryn, let me start with you because this is a topic we had discussed in the group. What there's a lot going on right now. What's the mindset you got to have right now to innovate?
We had an opportunity to talk with each other, and I think probably many of you are with your peers and within your organization, that this is a moment where we have to will ourselves to be open to all of the innovation at a time when it can feel that we need to close down or hunker down or focus inward. Frankly, both things have to happen. We have to keep our organizations on track and sustainable for the future. But for this to be a time of innovation and change, each of us as individual actors and leaders are going to have to regularly reset that mindset to being open to all of that, and not always long for the way that it used to be, because that was known and the great unknown. And that's not easy. And I admitted to this group that I was happy to say it here because I have to say it to myself quietly 8 times a day. So.
We have just a few seconds. Does anybody want to add to that point?
No, I think it's all about the community, right?
Yeah.
That's kind of the message today, the connections in the community, the relationships, and that improves the health and outcomes in the community.
Yeah, and I would just underscore, we've talked the same language within our organization. We can't kind of hunker down and kind of hope it passes. We have to become really innovative and really strategic around, priorities are going to have to be set maybe in a different way, but how do we take this moment in advance? How do we make sure that we're continuing to meet our mission?
Accept new ideas, maybe give up on some old ones that weren't necessarily working, hard look, right? Okay. This is a great group. Please give them a hand. Thank you very much.